Okay, so in this video, I'd like to talk about my day-to-day schedule as a level 2 fieldwork student for occupational therapy in inpatient rehab and acute care. I'm going to talk over some things. I am in a hotel bathroom because my apartment is still under work after the apartment fire. And I have made a similar video like this about doing a sniff placement for level 2, and so if that would be helpful, you can check that out as well. So I had a fieldwork placement this time around that was straddled between inpatient rehab and acute care. That's not, I guess, standard. From what I understand, in most places you'll do one or the other, kind of a unique situation. So inpatient rehab is, at least where I was, in the hospital, when people are deemed medically stable, and they have a diagnosis that fits in with what we rehabilitate in inpatient rehab. Then they can be considered. They have to be able to handle 3 hours of therapy a day between PT and OT. And the idea is to kind of to get them in and out in about 2 weeks, back to being independent, or supervision sometimes. And then acute care is seeing anybody in the hospital. So from like the emergency department, observation, where they have a room, but they're not admitted technically, even though they're staying overnight, or inpatient, where they are staying overnight, maybe a little longer for some more critical illness. And so that can, when you're in inpatient, that can be like ICU, CVU, high-level care. It can be a little bit of anywhere. And so we would kind of go all over the hospital. So if I was to have a placement in just inpatient rehab, from what I understand, you might have 4 people a day, because you see each of them for about an hour and a half. Because of the straddling of the two, we often saw between 5 and 8 people a day, just depending on whether we had more inpatient rehab or more acute people. And so I'm going to tell you a little bit about what my daily schedule would be, and then kind of go over the differences between the two evaluations and I guess some tips I have. So for me, I would get there at 6:30, and we would check if anyone had been brought to the inpatient rehab unit, because OT has to do their evaluation kind of first thing in the morning so that they can get the rest of their therapy throughout the day, because we set the plan of care for the CODAs, or the occupational therapy assistants, to work on, and without our goals they can't work with them. And also because we have to look at all ADLs. So we do a full ADL session. That way we can look at all of the aspects of taking care of yourself and gauge what we need to do to get them back home safely. So if we're going to have one of those, that'll set how many acute care patients we can take, because they're so long. So we'd look if anyone had been admitted, and then we'd go over to a folder that had all of the therapy referrals for the day and pick out an amount depending on, the load. And so then once we had done that around 6:40 and until 7:30, we'd start chart review. In acute care, that's one of the tips. Chart review is very, very important. You need to be checking all of the aspects. So I recommend watching how your fieldwork educator does it, what tabs they check on. That way you can write it down when you're still learning and just follow what you have written down so you don't miss anything. I've definitely had a few situations where I missed something and felt really silly when we called their nurse to see if we could see them, and they gave me a bit of information like, oh, they had a surgery or something that I had somehow missed. That meant, of course, we couldn't go see them. Now, if we did have an inpatient rehab patient, their chart review would be much easier because they've been seen by an occupational therapist on acute care, so we can look at that evaluation and those treatment notes. And also, they have to be medically stable to come to inpatient rehab, so there's not as much going on with them. So often, if we had somebody for inpatient, we would just start their evaluation and we wouldn't chart review on any of the acute care because it's just going to take so long and we need to get it done early. So we'd either do that first eval or chart review, and depending, let's say we finish around 7:30. If we did inpatient, we'd type it up and then start chart reviewing. If not, then we'd go out onto acute care and start our evaluations and treatments. So where I was, there were enough codas that OTRs didn't tend to pick up any treatments unless the numbers were really low for evaluations. We'd mostly only do evaluations. But anyway, we'd go out and start seeing our people. And we'd do that until around 9:15. At 9:15, we had to come back for our inpatient rehab conference, which in inpatient rehab, sorry, my eye keeps itching. At least where I was, there was a daily conference where we went over kind of the status of each patient, because you're working with insurance and everything so closely, their discharge dates can fluctuate, and also we're working with the doctors to talk about if we think any more testing needs to be done or if anything needs to be changed so that they can participate in therapy better. And that would last sometimes very short, 15 minutes, sometimes an hour. But if it lasted an hour, we'd get back out at 10:30, just doing more acute work. Then at 11:30, we'd come back to chart, write up our evaluations, write up our treatment notes. And then we'd take a 12 to 12:30 lunch. Then we'd go back out and do the same thing. You know, you're seeing patients, and then you'd type those up and you'd be done for the day. It's much less diversified, I guess, as my nursing home schedule was. There were just so many more patients that we had to see in the nursing home, and we were doing treats way more often. But yeah, there's just a higher level of acuity. They're more fragile in the hospital, so you can't see as many people, and their sessions might take longer or be more complicated. And especially in acute care, you get a lot of holds where they're not medically stable for you to see them, or they have a test or something when you go to see them. Okay, and so now I want to talk through kind of what an evaluation for each side would look like. I really appreciate that I got to do both sides because I think it'll help me in picking out a position in the future if I had the opportunity. And also, it might be good for you to hear if you're going to one or the other. So for inpatient evaluations, inpatient rehab, they normally take between an hour and an hour and a half, which is long. And first we'd start with questions. In like that interview portion, we do some manual muscle testing, range of motion testing, neuro testing, just to see what's going on with them before we start to move, kind of get a picture of how safe different things would be. We might also do a cognitive screen. For inpatient rehab, we had to do a cognitive screen, which was just the BIMS. Then we'd start taking their vitals because we get orthostatic blood pressures on everybody. And then I'd set up the room for a transfer. So I'd make sure that everything is in the place it's going to need to be once we start moving, including checking that the bathroom and all of the areas of the bathroom are clutter-free and ready to go. And then once I'm ready, I would turn off the alarm. But especially in inpatient rehab, you have to do a full ADL session. So I would need all of my supplies, towels, a bag, soap, hairbrush, toothpaste, all that good stuff. And so I wouldn't take off the alarm until I had everything in the room and everything was set up so they didn't move and then fall on me. Once everything was ready, we'd get to the edge of the bed, take blood pressure seated, and then we'd stand, take another blood pressure, and then we do the full ADL session. So we go in, they use the bathroom, we go over to the shower, they take a shower, we get dried off and get dressed, they brush their teeth, comb their hair, and then once all that's done, which can take a long time, we get them set up either in a chair or back in bed with the alarm on, and their call bell, and then we leave. One thing that was really important for inpatient rehab, because you are doing that shower, is knowing what can and cannot get wet. So heart monitors that are meant to be worn I think it's 30 days or something, they're like stickers with a little box on them. They can get wet, but an IV or a HEP lock, not an IV, cannot get wet. So in order to get them into the shower, we needed to get a waterproof bandage to seal it off. You can kind of learn that on the go, but it's really helpful if you look ahead of time at common lines and if they can get wet or not. Surgical dressing, you get a lot of fractures, so you need to know if their surgical dressing can get wet or not. Normally they can, but And then on the acute care side, evaluations are much shorter, and so is the paperwork. It can take 15 minutes. On the longer side, it might take an hour. Because the patients are more fragile, you might want to coordinate with a physical therapist. So I would do a chart review, and if I saw that they had severe dementia or emotional disturbance or not severe dementia, if I saw that they had dementia or some psychological concerns, you wouldn't want somebody coming in super frequently. You want to minimize that, so we try to coordinate with the physical therapist who had them to go see them. Or if they require a lot of assistance or have a lot of lines, it can be helpful to have that extra set of hands, so we'd coordinate. But we'd go up to the floor once we did a chart review. We'd call their nurse. You have to get the nurse's stamp of approval that they are currently medically safe to be seen by occupational therapy. And then we do a little interview. We'd start getting orthostatic vitals. I would look on their board because they'll put if they're NPO on their board, and that can affect what ADLs you can do. And also, people love to ask you for water when they're not supposed to have it. So you want to know before they ask, because I've made the mistake multiple times of saying, all right, let's brush your teeth. And then I look up and they're NPO and I have to walk it back. And normally they're really sad because they wanted to brush their teeth. So then I'd ask them what they wanted to do, also keeping in mind what I've just seen on my little workup, doing their manual muscle testing, range of motion, a BIMS if I felt like I needed it. Often our goals are just to get up into a chair if we can and do teeth brushing, changing a gown, changing socks. We're not going to get a full ADL in acute care normally. So then I'll go grab those items. again, not taking the alarm off until after I get the items. I'll set up the room and their lines to be ready to transfer. We'll get them out of bed, take some more vitals. If we can, we'll stand and transfer over to the bedside chair, making sure it has an alarm pad on it first. But sometimes people are just too sick, like often they're too sick, and so we'll just get edge of bed and sit there for things. And if we have to lay back down because they're not feeling well, we'll lay down, maybe even do some like teeth in supine. But yeah, if we can do the most we can do, we'll get up and get into a chair or go to the bathroom and then brush our teeth. If somebody has already done everything and I'm just trying to see if they need occupational therapy and they don't want to brush their teeth, they don't want to go to the bathroom, I'll just say, like, can I see you take your socks on and off? The doctor wants me to check how you're moving, and that's something I like to see. Especially because people will tell you they can do it and they can't do it. So it's good to actually see. And then once we're done, I'll put on the alarm, whether it's the bed or the chair alarm, and then I'll give them a call bell and we'll be done. Another thing that's important in inpatient and acute is knowing medical terminology, just common medical terminology. That can be really hard to learn in that first week if you didn't already prepare, because you're also trying to learn how to be an OT at the same time. And then a lot of what I had to get good at in inpatient and acute was just talking to people, specifically conveying like why I was there, because they have so many people coming in and out all the time. So I wrote down some common phrases that I would use. So, you know, the doctor wanted us to come and see how you're doing and like doing the stuff you need, or the doctor wanted us to come and see how you're moving. That gives that little bit of authority of you might not think you need occupational therapy, but the doctor just wants us to check, and that's part of like getting you back home or getting you back where you're gonna go. I often won't say home because I don't know if they're gonna go home. I'll ask if people have had occupational therapy, and they'll normally say no. And so I'll say, you know, sometimes when people come into the hospital, they're sick, and that can make it harder to do the things you need to do. And so that's why we're here to check you out. And then I'll say, you know, OT looks at you doing your day-to-day activities, especially in acute care, we're looking at, you know, list the things you want to look at. So you brush your teeth, getting dressed, just because you might be pretty worn out. And then if they're asking about physical therapy, or that, you know, they just saw therapy, you can say, oh, that was physical therapy. They focus on your mobility, or you walking down the hall, how far can you get, like your balance, and if you're having any muscle pain, just to give a differentiation of who we are, who they just saw, because it's very chaotic in the hospital. So that was my day today as a inpatient rehab, acute care, occupational therapy level 2 student. I don't want to make this too long. I'm going to make another video of like what I carried with me while I was doing my field work. But for this video, I'm going to stop here. I also have a video like this and a video of what I carried with me in my last placement if you are going into a SNF, and hopefully that can help you. Bye.